something that y'all might tell us about your successes with unlikely political allies?
Sure. In New Mexico, we've seen increasingly and incredible bipartisan support for these issues. And, as we've talked about from a range of different perspectives, but really looking at how we can no longer move forward in this way. In New Mexico and across the country, women of color and Indigenous women make up the fastest growing prison population. So our prison in New Mexico is absolutely at capacity, and they've done everything they can to put in multiple bunk beds and rooms and all those sorts of things. And if something doesn't change urgently, they're building another women's prison in New Mexico. So like I said, it really takes centering the expertise of people who've been incarcerated, who've been in cycles of addiction, to talk to lawmakers to make these real issues. The Republican co-sponsor of our Ban the Box bill this year came to that bill because he had had a longtime loved one who had himself been incarcerated and been able to build himself a life after that. So it takes really humanizing these issues that lawyers and docs and social workers are not always the best people to talk about them. That when we give people the opportunity to share their own expertise, it's really meaningful in creating change.
I would agree with that. Did I just turn myself off? I would agree with that. I've also found, I spend a lot of time in my job advocating to congressional offices. And I've spent most of that time over the last 2 years really trying to work with Republican offices who have traditionally been less inclined to invest in health and social services programs, and perhaps not to stereotype, but more supportive of more traditional law and order approaches. And I've really found a kind of sea change, and that part of that is about they're hearing the same messages from a very diverse group of voices. And we work with ACOG, the American Medical Association. We work with the National Safety Council. We work with a lot of different public health groups, a lot of different treatment and recovery groups. But we're also hearing a lot of different voices. A lot of parents groups, a lot of family groups have been getting very involved and vocal about overall public health approaches to, and I'm thinking in particular, the opioid and heroin crisis. So I think that the Unite to Face Addiction rally is a manifestation that this could not have happened a few years ago in the same way. And there's been a real effort to kind of build a big tent, try to bring in labor groups, civil rights groups, and work beyond the traditional kind of professional voices. And I think that that's what it's going to take to move and change these policies.
Well, I will say the 911 bill I talked about, as well as the Sharps bill that we at TADIS work on this year, we did come together with a broad coalition of people, Tennessee Medical Association, Tennessee Hospital Association, and perhaps some unlikely allies, the Tennessee Sheriff's Association and some law enforcement associations across the state became our allies on this, and I was pleasantly surprised. So you need to look beyond your usual borders.
Yeah, I was going to say the same. We have found some unlikely allies in the criminal justice system in North Carolina. So as was mentioned with drug courts, I had the opportunity to go and present to drug court the district attorneys, the judges, probation officers about medication-assisted treatment, and was able to talk about if you are thinking that you want someone to complete drug court in a year, and this is the appropriate treatment for them, and the judge was like, so it's not going to work. It's not appropriate to have them finish it. And I'm like, bingo! Like, you get to talk about for that one, because I always think about candy when I do trainings. But it was one of those things that was really great. It was kind of this aha moment where one of the judges really got it. Like, it's not appropriate to have this nice little thing wrapped up at the end of treatment. So the fact that they were open to having someone come in and do a training on treatment, and specifically medication-assisted treatment in the drug court system, was really great. And if anyone is interested in doing something like that here, please let me know. I'd be happy to share any insights. And we also in North Carolina, through the advocacy of the North Carolina Harm Reduction Coalition, again had a very diverse coalition of supporters for our Good Samaritan 911 call and also the access to naloxone law. So again, the Sheriff's Association was a big supporter of that. So these unlikely allies are starting to sort of come on board with some of these things that when they weren't a number of years ago.
So the folks who are gathered here today, who are seeking fair and effective policies for pregnant drug users in Tennessee, have a big challenge ahead of them in the coming months as they work towards the sunset of this law. And so I really hope that you can address them, give them what is your best piece of advice for the road ahead, based on the work that you've done.
I just turned it on. Okay, so this is, I think there's two layers to this. One is about what I kind of suggest about reframing the issue, because to a certain degree, I think part of successful advocacy is figuring out with policymakers where the common ground and common goals are. And I think going back to my sort of like, what does a harm reduction lens look like? First, I think we want better outcomes for infants who are diagnosed with neonatal absence syndrome. We may want to think about strategies to perhaps reduce the severity of neonatal absence syndrome. If possible, reduce the incidence of it. But what are the outcomes that we're really concerned about, and how do we get there? And I think that part of that is we've heard ample evidence today that this legislation is not getting us there, right? It has not done anything to change the incidence of neonatal absence syndrome. And I think the point earlier that relying on the Finnegan score is probably to some degree distorting the picture of how we're defining the problem. But I think beyond that, if there is a shared goal to minimize harm and suffering, then there are plenty of gaps in the system right now in terms of what we can offer women and how we can facilitate their better engagement and utilization of care. So I don't think that it may not be sufficient to say just let the law sunset. I think you have to provide some alternatives. Now, unfortunately, some of those alternatives in theory require different kinds of investments, and there may be spending constraints or considerations there. But that is also about holding people to what they say they value. If you value this, then it will require some investments, but those investments will pay off for the health of the mother, the children, and the entire family and community.
My spiel already was a little bit about how to move the process forward, but I will say, beyond just treatment for pregnant drug-using women, we just have a huge shortage of treatment funding for anyone in the state of Tennessee. Right now, the data that I gave you this morning from the Department of Mental Health and Substance Abuse Services, oops, wrong one, I have it here. Anyway, that data is from state-funded treatment programs. And that state funding every year treats roughly around 13,000 people per year. That is a drop in the bucket for what it is we actually need to provide. There is that funding, however, comes exclusively from the federal government. There is no state funding in the state of Tennessee for indigent treatment funding. And we have a huge waiting list on any given day for treatment slots, whether you're a pregnant drug-using woman or not. And without putting some serious emphasis on addressing access to treatment, we will never begin to address this problem.
Like I've been saying, and I'll keep saying, thinking of meaningful ways to include folks who have been most impacted, and that takes significant investment in community, that it's not a one-time thing that you ask someone for their story, use it, and then leave, but you build ways for people to create meaningful change that they can also get healing and find substance from. We've talked about finding unlikely allies that, it's gonna take making everyone feel this is their issue. We've heard all day today about how people who use narcotic, illicit drugs are absolutely separated from those who are prescription using. And, to be completely freak and organizing, you need critical mass, so we need those who have money to think this is just much their issue as those who are in street economies, and how we can bring people together across those separations of identity and still focus on people who are most marginalized, but get that critical mass of advocates. And then I think lastly that messenger really matters, that it takes finding that one person in the prosecutor's office that's on your side and having them be your advocate to the rest of the legal system, or finding that judge that's really with you and having them, because so often who we hear the message from really matters, and that we need to take that into consideration, that while we need to have message unity, that it matters to have some individuality too, because that's the really way that we're going to be able to move people across identities.
Again, thinking about strategies with this issue, when we hear news stories, when we see reports on neonatal abstinence syndrome or neonatal opioid withdrawal, what do we see? We see babies in incubators in NICUs, right? And what I've started doing is women that have been in methadone treatment and have delivered babies, what I've been asking them for is pictures of their babies and pictures of them with their babies. And one of my favorite pictures is this baby on a scale, and it reads 8.3 pounds, right? And this is an infant that was exposed to methadone. Mom was in treatment, not using any other illicit drugs, had quit smoking, had a stable home environment, decided to breastfeed. She'd done all the recommendations that we had told her about. And what it does is that it makes her feel empowered. Like, look, my baby's doing so great. I made good decisions for myself. And then also it helps other women feel more likely, like, oh, I can go into treatment. This doesn't have to turn out with my baby being in an incubator. So sharing these messages of success stories in a way that's safe for women, and for me personally, I don't necessarily share pictures of the women themselves because there could be some fallback from that, but pictures of babies are pretty okay. So I've started using those in my PowerPoint and asking people, which one is the one that's been exposed, and it's like, it can help people kind of change their perception. And that's important for both women to understand, providers, and especially our people in legislature and political power.
I come to this room for a lot of different reasons, but I want to speak right now as both a social worker and substance abuse counselor, but also a mother who's approaching my 4th year of sobriety. And I feel like for a day that has really focused on patient-centered treatment options, we haven't heard from any of the women who are directly affected by the issue today. And we've heard a lot of really great things from experts, but that we can be experts on our own lives too, and are capable of speaking for ourselves. So mostly I just want to recognize that I know there's other people in the room too who are directly affected by the issue, and there's people that cannot be here for whatever reason, whether it's because they are incarcerated or in treatment or don't have the privilege of being able to access spaces like this. So I just wanted to recognize them as well, and just bring that to the space.
While we're recognizing, I wanted to recognize the undocumented population that we have in Nashville and Tennessee, all over. I was really struck by Denisia's comment about people who are here through non-volitionally, through economic circumstances or what have you. For those patients, obviously TennCare is not feasible, nor is relying even on the criminal legal system. 911 Safe Harbor doesn't even seem to be helpful for them, not only because of the language barrier, but also because of a justifiable fear of law enforcement in general. I think even these drug courts are off limits because it's advisable in most cases to avoid as much contact with the legal system as possible. So I was just kind of curious about what you guys have found is helpful in funneling people who are undocumented to the treatment that they choose.
So thank you for your question. And I want to first say that it's absolutely impossible to talk about the impacts of cycle of addiction without talking about identity. So we haven't heard anything about LGBTQ or two-spirit people, and we know that the marginalization that our communities face push them much closer to cycles of addiction and healing from trauma. And that's absolutely true for undocumented folks too. In New Mexico, we have just a single clinic in the whole state where folks can go get sliding scale care, and they thankfully do take both medication and indigenous approaches to healing. So there's acupuncturists that provide support for people who are in recovery, specifically doing needles and that sort of thing for their healing. And then there's also access to different types of medication-assisted treatment. But I think what it really points to is, like you're saying, we've created healthcare systems that criminalize people. So, we've worked with so many mothers, whether they're undocumented or not, that have gone in, sought care, were not told that their urine screens were being tested for drug use, and on the day of their birth, have their children taken away from them by CYFD, which is apparently DFS in the state of Tennessee, but the Children's Support Division. And what it takes in the medical system to build providers that are competent across documentation status, across sexual orientation and gender identity, across cultural competency, because our families are not being criminalized in the same way that Black, Indigenous women and other women of color, that people who are queer or trans are being criminalized in different ways, and our healthcare system is the one that's doing it. It's not even, a separate criminal justice system. When people are seeking care, they're going in for that. So we have to build culturally responsive models. The Native Youth Sexual Health Network talks a lot about building systems outside of the criminal justice or healthcare systems that are coming of age ceremonies to restore traditions between elders and young ones and do some of this sort of community healing that just won't be possible in either of those systems.
Talk a minute about Tennessee's access to care for undocumented folks. There is a broad network of faith-based programs that do actually provide access to some levels of care, not necessarily residential treatment, but there are some what I would call like residential wraparound type programs. Most of them have licensed clinicians that are a part of those programs, not all, but most. And there are certainly other types of programs, including peer recovery support programs that are peer support centers, as well as AA and NA and some other things that are accessible. There are also clinics in the state of Tennessee that have programs that are funded through their own private fundraising. And they're not necessarily spread across the state, but one of the benefits of having the Tennessee Red Line is that we have all of that information. So if someone calls us, we can connect them to a faith-based program that where they don't need to pay for services.
Does that include medication assisted?
Medication-assisted treatment would not necessarily be provided by a faith-based clinic, but some of our community mental health centers and other clinics that have foundation-sponsored treatment, a few of them do, yes.
Hi, my name is Jenny and I'm from Australia. The reason I'm here is because I was collared by Lynn Paltrow at the airport at New York yesterday when we discovered we had a mutual interest in reproductive justice. I work for Women's Health Victoria, and we are also very concerned with maintaining the issues of reproductive rights, prevention of erosion of laws that protect women. And I would have to say how wonderful a privilege it has been to be here today and hear the wonderful work that everyone's doing. We grapple with similar issues, and perhaps one thing I would like to say is that we can also look beyond state borders to international ones and learn from each other around the globe and look at the efforts of the UN, the World Health Organization, and the principles upheld at the highest levels. Because if we can get some universal agreement in those things, we won't have all these state-based differences. And in Australia, we have 7 different laws relating to abortion in 7 different states. It's the similar issues, the similar legislative erosions of justice. And anyway, thank you that I can be part of it, and I hope you achieve everything that you set out to do.
Feel free to please flag down our microphone, Jules. She's right there.
So I was wondering if you could address what it means to be a faith-based treatment program and what evidence-based research supports that, and whether it means if you don't agree to the religious views or abide by how they expect you to express those religious views or participate in religious service, what happens?
Okay, the faith-based providers are sometimes referred to as access to recovery providers. It was a group of providers that was originally funded under the Bush administration as, you remember the 1,000 Points of Light and how we were all going to be part of a faith-based network. Those providers were funded not only in behavioral health but also in physical health. There's not one answer for your question. Different faith-based providers, provide access to services differently, but they are not supposed to be proselytizing. It's part of their funding. When they were originally given the funding, they're not supposed to be there to convert people or to provide access to only one religion or another. You hear anecdotally that may or may not be true, but in theory, they were not funded to do that. There are providers here in Nashville, such as the Rescue Mission, the Lighthouse Mission. Those are faith-based providers. And there are in Memphis, what's it called? Is it the Rescue Mission in Memphis? Yes, they're a faith-based provider as well. Does that give you kind of a visualization?